I'm going to review some groups that experience disparities. I'm going to briefly talk about insurance coverage for adults, and then I'm going to review some evidence-based anticipatory guidance, some local referral resources, and future directions in pediatric dental care. So this Grand Rounds presentation is designed to get us to use evidence-based care to explore a specific topic. So I wanted to go into a little bit of some of the resources that I used to look at this topic specifically. I had the usual suspects, UpToDate, PubMed. I looked at the CDC for some statistics. I also utilized our Maine Med librarians to help me with literature reviews and accessing journals. One of my favorite resources that's available in the library resources section is Dynamed, and that has bullet points and with specific references to the level of evidence. And I also participated in a Maine AAP town hall on pediatric dentistry earlier this year. Disclaimer too, because of the nature of this topic, a lot of my papers are cross-sectional surveys that have very dense tables and not a lot of great graphs. So just bear with me as I go through some of them. So as with all presentations, this was inspired by a couple of cases. The first one is a 5-year-old girl who is a child of Rwandan refugees who presented to the peds clinic with tooth pain. Her teeth hurt whenever she ate ice cream, and she had evidence of dental caries on exam. She had never seen a dentist before. My next patient was one that I was introduced to in the Med Peds clinic. She came to me to establish care after being hospitalized for an empyema and bacteremia. During her hospitalization, she had all of her teeth removed for very severe dental disease, and she was coming to me asking how she could get dentures through Maine Care. So these cases drove me because I feel like I don't know enough about dental care, and I certainly don't have enough time to go in depth about dental care with each one of my patients. So my first step was to learn a little bit more about the burden of dental disease. And these are a couple of statistics that really sat with me. First off, dental caries are the most common chronic disease of childhood. And as someone who's training to take care of chronic childhood diseases, this kind of struck me that I felt like I really didn't know enough about this. And there's certainly an issue with access to care because in kids less than 1 year old in the US, 88% had regular doctor's appointments, but only 3.6% had regular dentist appointments. And having grown up in Maine, I definitely heard that dental care was a problem. And this is borne out in the numbers as well. According to a parent survey in 2015, 16% of children did not receive any preventative dental care. And according to claims data in 2017, 42% of children on Maine Care, only 42% of children on Maine Care had a dental visit compared to 67% of kids that had commercial insurance. And by the 3rd grade in 2017, 4 in 10 Mainers had caries. And this is particularly problematic because poor dental care has been shown to be associated with multiple medical conditions as well as other issues. So this is a study that was published in 2017 in the Journal of the American Dental Association and looked at about almost 12,000 kids in a large national study across the US. And they looked at them in their teenage years and then their young adult years and looked at whether they had delayed dental care in those teenage years and then looked at a variety of medical factors. What they found is that if kids deferred dental care in this teenage year, their teenage years, when they were adults, they were more likely to have an elevated BMI, and they were more likely to have an elevated blood pressure and more likely to be diagnosed with hypertension. Now, I will point out that this is all association, not causation, but the kind of underlying theory might be if a child had poor dental care, then they might have poor diets, which lead to these increased cardiometabolic risk factors. There's also been evidence to show that dental disease is associated with difficulty in school. This paper was a cross-sectional study published in 2011 in the American Journal of Public Health, and it looked at 2,000 kids across North Carolina. And what they found was that kids whose dental health was listed as good, fair, or poor were 3 times more likely to miss school for dental pain compared to those whose dental disease was rated as very good or excellent. And that is probably intuitive, but another thing they found were that these absences related to dental pain were more likely to result in poor school performance compared to those absences for just routine preventative care. And these negative effects are not spread evenly across all children. This is data from Maine, and it shows that there is a significant gap between kids who are on Maine care and kids who get commercial insurance in terms of their access to preventative dental care. And the other thing I want to point out is there's a significant fall off as kids age with their preventative dental care. And this is particularly problematic because across the US, 14 states, including the state of Maine, have no preventative coverage for adults on public insurance. Now, because I'm an adult provider, I specifically looked through the Maine Care Reimbursement Manual, and it was super depressing. Adults, so people older than 21 who are on Maine Care, it only covers extraction, and it only covers extraction if you either break a tooth, so if you had a traumatic injury, or if your teeth are severely decayed enough so that they pose a serious threat during another surgery or radiation therapy. And this is language taken specifically out of this manual. And if you get your teeth removed and you want to get dentures, you can only get dentures if they're medically necessary. So you have to have that documentation done. And if you get over that medical necessity bar, that's fairly high, you better hold on to those dentures because you only get one set in 5 years. So you better not lose weight, gain weight, or lose your dentures, or else Maine Care won't cover them. So we've identified that poor dental care is a problem, but we still don't, at least I still don't feel like I have enough time to talk to my patients about it. So that comes to the crux of this presentation, which is who do we target? Who's at risk? And there are multiple risk assessments out there from all of these different organizations. The one that I listed here at the right is from the AAP. But this is just another form for parents to fill out. We have lots of forms we give out before appointments. So I wanted to distill it down to the risk and protective factors to go over with you guys. So the AAP lists these as risk factors, and they include the presence of maternal dental disease, continual bottle or sippy cup use with a drink other than water, frequent snacking, kids with special healthcare needs, and kids who are Medicaid eligible. Protective factors include kids who have a dental home, kids who have exposure to fluoride in one way or another, and kids who brush their teeth twice a day. One group that isn't mentioned, but that I wanted to look into were people of racial and ethnic minorities. As we know, folks of racial and ethnic minorities are at a disadvantage across the healthcare system, and dental care is certainly no different. This is data that comes from the CDC, and it found that Black and Hispanic children were more likely to have untreated caries than their age-matched white peers. And that was whether they were in the preschool age, the school age, or the teenage, in the teenage years. They also found that they had poor access to preventative care, like sealants, whether in the school-aged or the adolescent groups. This paper was published in the Journal of Public Health Dentistry in 2020, and it was a cross-sectional study of about 1,000 kids in northeastern Ohio. And they looked at Black children compared to non-Black children. And what they found were that Black children were more likely to have been to the hospital or emergency department for dental-related issues within the last year. They were more likely to have a lower oral health quality of life score, and they were more likely to have poor access to food. Please bear with me with this slide. these disparities between race were also seen in the rates of dental disease. So these were actual dental examinations that were performed on these children. And as you can see, all of these p-values, well, most of all of these p-values are significant. And what they found were that children who identified as Black were more likely to have disease in both their baby teeth as well as their permanent teeth compared to non-Black children. But I wanted to make sure that my talk was targeted and tailored to Maine, and a large portion of our non-white population in Maine are relatively recently arrived immigrants. And so the next few papers that I reviewed look specifically at refugees and asylees. This is a Norwegian paper that was published in 2018 in the Journal of Immigrant and Minority Health. And it looked at adult men that were grouped either into coming from African countries or from the Middle East, which brings me to a point. A lot of these papers that I'm going to review about immigrants do this, where they group people into region of origin. And that can be somewhat fraught because, as we know, Africa is a very diverse continent, and they kind of all group them together. So just something to keep in mind as I go through this data. But this study was looking at adult refugees and asylees, and they asked them about their habits both before and after arrival. And what they found was that the African cohort were more likely to have never seen a dentist compared to their Middle Eastern counterparts, 4.4 versus 48%. And once they arrived in Norway, they found that 82% of the participants did not have regular dental visits. However, they cited different reasons for not accessing care. The African cohort talked about not really needing care, whereas the Middle Eastern cohort cited cost, a difficult to navigate system, and difficulties with language barriers as being the top 3 reasons to not access dental care. And these variabilities in between immigrant groups are also present in the pediatric data. This study was published in 2019 in Pediatric Dentistry and looked at about 200 kids going through the refugee health program in Providence, Rhode Island. Again, they were grouped into region of origin. Their African region looks very similar to ours. They have folks from the DRC, Somalia, Burundi, and Rwanda. Their Asian population is a little bit more diverse. They include folks from Syria, Iran, and Iraq, but they also include people from Myanmar and Thailand. The other group are mostly people from South America, but because their numbers were so small, they weren't included in the rest of the data. What they found was that patients in the Asian group had a higher risk of caries compared to the African population, and this was significant. They also found that they were more likely to require either urgent or emergent intervention on those caries than the African group. One kind of downside to this study, though, however, is that when they looked at the demographics, the Asian population tended to be a little bit older compared to the African group. And age can affect your caries rate, so that may have been a confounder. Now, this study compared refugees between either region of origin, but then also compared them to US children using a large national survey. It's a little bit older. It was published in 2004 in Pediatrics, and it looked at about 200 participants that went through the refugee health program in Massachusetts. Again, they had an African cohort that were from mostly Somalia, Liberia, and Sudan, and these were predominantly Black. And they had an Eastern European cohort that were mostly from Bosnia, and they were predominantly white. What they did was they talked to all of these groups and asked them about having a history of dental disease, and then they examined them to look for active untreated caries. What they found was that there were significant differences for how the different groups of refugees interacted with dental care before arrival. The Eastern European cohort were more likely to have been to a dentist and have used a toothbrush in their home countries compared to the African cohort. Despite these habits, though, they actually saw a heavier burden of dental disease in the Eastern European group. these folks were more likely to have had dental disease in the past, to have active untreated dental caries on exam. And when they did have untreated dental caries, they were more likely to have lots of them. So the majority of the people in the Eastern European group had at least 10 caries when they were discovered. And there are a couple of different theories why this might happen. It seems like there's something intrinsic to the environment of their regions of origin. And this could be maybe the African cohort were less exposed to refined sugars, or maybe the prevalence of cariogenic bacteria is lower. But another potential possibility is some of the habits or dental practices that were asked about. Maybe the African cohort have different cultural practices that weren't really encompassed in that European-centric idea of dental care and toothbrush use. When they compared these refugees to US children by race, they found that the Eastern European refugees were 2.8 times more likely to have had caries than white US children. But after they arrived, they were 9 times more likely to have active untreated caries. When they compared the African refugees to Black US children, they found that they were half as likely to have had caries in the past, but once they arrived, they were just as likely to have active untreated caries compared to Black US children. Now, again, there's some different conclusions that can be drawn from this. Again, it seems to support that there is a environmental issue, or there's an environmental cause in the US that increases the rates of caries. But the alternative answer could be that, you know, maybe the refugee groups again had less access to dental care, so they just weren't being diagnosed with caries until they arrived. The next group that I wanted to talk about are children who come from low-income families. This again is the data from the CDC that looks at the rates of untreated caries. And again, in every age group, the kids who were below the federal poverty level were twice as likely to have untreated caries compared to their age-matched peers above the federal poverty level. And just like racial and ethnic minorities, they were also less likely to have dental sealants than their peers above the federal poverty level. And this is problematic because as these groups age, they are at higher risk of losing their teeth. This graph looks at tooth retention, so basically maintaining a full set of teeth. And what they found is that Black, Hispanic, and children below the federal poverty level were more likely to not have a full set of teeth compared to their white or more wealthy cohorts. The final group I wanted to review are children with special health care needs. Just like immigrants, this is a very heterogeneous group, so I wanted to highlight a few specific diagnoses. This paper was published in BMC Oral Health in 2013, and it looked at a bunch of different factors in the prevalence of dental disease. It looked at about 100 kids in Head Start programs across Washington state, and they specifically wanted to look at whether developmental delay was associated with a higher rate of dental disease. And they found that this was in fact significantly true. The kids who had developmental delay were more likely to have increased caries compared to their peers, but they also found a few other risk factors that may sound familiar. And this includes older age, difficulty communicating, coming from a household where the parents have a lower educational level, not having an access to a dental home, and not having access to fluoridated water. In the same year, this study was published in the International Pediatric Dentistry, and it looked at autism spectrum disorder. This was a case control study looking at about 200 kids in Egypt, and they compared kids who held a diagnosis of autism spectrum disorder based off of the DSM-4 criteria, and then they had controls matched to age, sex, and socioeconomic status. What they found were that kids who had autism spectrum disorder were less likely to have seen a dentist in the previous year, and that they were more likely to say that it was difficult to find a dentist, which is not really surprising. They also found that there were other behaviors that are associated with increased risk of caries that were more likely to be, that the patients with autism spectrum disorder were more likely to have. And this included that they were less likely to brush their teeth, they were more likely to have difficulty brushing their teeth, and they were more likely to require supervision in order to brush their teeth. They also found that kids with autism spectrum disorder preferred sweet snacks over fruit snacks. But as I mentioned at the top, not all children with special healthcare needs are the same. And this study, published in 2019 in Pediatric Dentistry, looked at about 150 kids over about 24 years in a private dental practice in North Carolina. And they split them up into these diagnoses, including autism spectrum disorder, congenital heart disease, cerebral palsy, Down syndrome, and then they had a healthy control. Now, what they found were kids that carried these diagnoses were, again, more likely to have some of these risk factors for dental disease. And this included, they were more likely to prefer sugary drinks or snacks. They were more likely to be on medications that induced xerostomia or dry mouth. They were more likely to have difficulty with oral hygiene, and they were more likely to have atypical diets that relied on either liquids, purees, or G-tubes. However, when they compared these different diagnoses to each other and to controls, they found that only one diagnosis stood out as being having more significant active dental disease compared to the control group, and that was congenital heart disease. And this I found interesting. I found a Canadian study that actually tried to figure out why this is. And in general, they found that kids with congenital heart disease tended to have poorer hygiene, a more cariogenic diet, and they were more likely to be on chronic medications that had a liquid sugar base. And that they also found that there was higher parental anxiety around stressful situations like dental visits that decreased their desire to go and see dental providers because of their concerns on the stress, what the stress would do to their children's hearts. So that was a lot to review, so I'm going to summarize a little bit. So there are certainly disparities that exist between racial and ethnic minorities and low-income children. They're more likely to have dental disease and less likely to have sealants. Immigrant groups are not all the same, and it seems like there may actually be some protective factors in the African immigrant groups, but only until they arrive, and then they start looking a lot more like Black US children. And not all children with special health care needs are, again, the same. Children with autism, developmental delay, and congenital heart disease seem to be more likely to have be at risk for dental disease and have more difficulty accessing care. So now that we've identified the high-risk groups, the next step is to figure out what to do about them. And that brings us to the pillar of primary care, which is anticipatory guidance. So as many of you guys know, Bright Futures is a group within the AAP that reviews and recommends guidelines for preventative and well care. The advice that I'm going to go over comes from a report they put out in 2016. So for the crew less than a year of age, they recommend encouraging parents to maintain their own dental hygiene, avoid bottle propping or kind of keep using bottles for soothing at night, using a washcloth on the child's gums, and avoiding using utensils and putting the child's pacifier in your mouth. These last two kind of interested me, so I wanted to look a little bit more into it. The theory behind it is that cariogenic bacteria like strep mutans have been shown to be transmissible on fomites like utensils and pacifiers. So that brought me to this paper that was published in 2011 in Carey's research, and it looked at Japanese 3-year-olds. Now in Japan, municipalities examine these kids yearly for dental disease. And they recruited basically all of the 3-year-olds from one municipality, which came out to be about 3,000 children. And they gave questionnaires to their caregivers and then did oral exams on the 3-year-olds. And they divided the kids into groups where the caregivers actively avoided sharing utensils and pacifiers compared to the group that said that they didn't try and actively avoid those things. Their initial evaluation showed that there was a significant difference between people who actively tried to avoid sharing utensils compared to those that didn't. However, when they controlled for confounders like age and sex, dietary factors, oral hygiene practices like toothbrushing, and socio and economic status factors, these differences were eliminated. They didn't see any continuing significance. For the 1 to 4-year-old crowd, they again they recommend discouraging thumb sucking and avoiding juice and sugary beverages. So I wanted to look up whether giving dietary advice was actually effective. This had popped up on multiple other studies citing sugary treats as increased risk of caries, and that certainly seems like it would make sense. So this study was in a Cochrane review from 2019. It was a meta-analysis that looked at, this section looked at 3 different studies, 2 from Brazil and 1 from the UK. There's a lot of pediatric dentistry data that comes out of Brazil. It included about 700 kids, and the studies all had a moderate grade of certainty. What they looked at was whether you gave advice to women who were either pregnant or had children less than a year of age, and you talked to them about encouraging breastfeeding, avoiding sugary drinks and beverages, and avoiding using bottles around sleep. And then they followed these children up to 6 years of age and looked for dental disease. And I'm very sorry about the quality of this graph. This is exactly how it looks in the paper. I don't know why it's so fuzzy, but what they found is that it's just fairly significant that the people who received that advice at early ages were less likely to have dental disease than those that did not receive that advice. So in the school age kids, again, you want to recommend avoiding sugary drinks, and you want to start talking to parents about having their kids wear mouth guards in rec and organized sports. The adolescent age group is, again, a really ripe time to talk about dental care. You are trying to prepare them for adulthood. So there is actually an adolescent transition toolkit that has a section on dental care that you can look at. But specific things you want to talk about are substance use, particularly tobacco and meth and its effects on the teeth. You want to talk about eating disorders, because anything with purging can increase your risk for dental disease. And you want to talk about piercings, because lip and tongue piercings can increase a child's risk of having tooth fractures. You may have mentioned or may have noticed that I hadn't talked about toothbrushing yet. I figured it needed its own slide. So according to Bright Futures, it recommends that as soon as a child has a tooth, that you start brushing their teeth. And this is always, they recommend always using a fluoride-containing toothbrush or toothpaste, sorry. If they're less than 3 years of age, they recommend using a smear. They demonstrate a smear here. They recommend using a smear and just leaving it on the teeth, so not having the kid rinse or spit. If they're 3 to 6 years old, they recommend using a pea-sized amount of toothpaste, and it's okay to spit, but again, you can recommend that they don't rinse at that point. They also recommend making sure that kids have adequate supervision to ensure adequate toothbrushing. And they say that kids really shouldn't be unsupervised brushing their teeth until they can tie their shoes, and then they also recommend that kids start, you talk to kids about starting flossing their teeth around 5 to 10 years of age. So I decided that I wanted to look up frequency of toothbrushing because I feel like this is not an insignificant question. I certainly feel like I have talked to kids who are like, hey, why do I have to brush my teeth twice a day? I already brushed my teeth today. So this is a meta-analysis that was published in the Journal of Dental Research in 2016. And it looked at 25 studies from around the world, mostly from Europe, predominantly from Scandinavian countries, all with either moderate or high quality data. And they looked at self-reported frequency of toothbrushing and then asked, basically, do the patients have caries? And if so, how many caries? This graph to the right, for those of you who are familiar with meta-analyses, is a funnel plot. It's used to detect publication bias, which is the tendency for studies to be published only if they have significant results. And as long as most of the studies are underneath the funnel plot, then you can be assured that the meta-analysis is not subject to publication bias. So this is a big table, so bear with me. The first group up here basically looked at studies in which they asked people, do you brush at least 2 times a day versus less than 2 times a day? And they found that people who reported brushing their teeth less than 2 times a day had an odds ratio of 1.45 and were more significantly likely to have caries. The next group looked at people who said they brushed their teeth at least once a day compared to those people who said they brushed their teeth less than once a day. And the odds ratio here was 1.56, so not too different than the one above. And again, favoring the infrequent toothbrushers as the ones who are more likely to have caries. And the conclusion that they kind of came to is maybe it doesn't really matter how frequently you brush your teeth because these odds ratios are so similar. But the takeaway that I have from this is basically if you didn't think you were brushing enough, then you probably weren't, because this is all kind of self-reported toothbrush frequency. So the Bright Futures guidelines can be used for all children, but there are also specific guidelines for kids with special healthcare needs. These are put out by the American Academy for Pediatric Dentistry, and they have a few key points. One of which is they recommend that that these kids have a dental home with flexible appointments, that you refer them to a dentist as early as possible, that all providers are aware of a patient's sensory triggers and issues, and that the dentist develops an individualized preventative plan based off of each child's needs, that we as primary care providers encourage a low-carb diet when able, and that we make sure that we're continually looking through patients' medication lists to make sure that we're limiting the medications that can cause dry mouth. These could be things like hydroxyzine or Benadryl. There's a whole list. So far, I've reviewed a lot of cross-sectional surveys, so I wanted to find one randomized trial. This was published in Pediatrics in 2018, and it looked at motivational interviewing. So basically, not just do you advise parents about ways to decrease a child's risk of dental disease, but how you do it. This was done in Brazil with about 419 kids, and it's a randomized cluster trial. And in Brazil, the kind of standard of care is that all children less than a year of age in this area of Brazil get evaluated in these healthcare units, which is basically a clinic, and that the kids are assigned to these units and then they continue following up in these clinics every year. So instead of randomizing by child, this study randomized by healthcare unit. And the kind of intervention group was the non-intervention group, the control group, was just conventional oral health education. However, the intervention group they got oral health education, but using the tenets of motivational interviewing by people who had been trained in motivational interviewing. And then and this was performed all while kids were kind of were less than a year of age. And then they followed up and did exams on them, looking for decayed, missing, or filled teeth for over the next 3 years. That's what that DMFS means. And what they found was that people who were in the conventional group were more likely to have dental disease than those who were in the motivational Those that were in the motivational interviewing group, they were less likely to see dental disease. However, looking at the demographic data, they found despite this randomization, the conventional group had significantly more mothers with either a lower level of education or from poorer households. So when they controlled for parental education and income, they found that this made a significant difference. So while prior to controlling for these, they had a significant difference between the conventional and motivational interviewing group. After controlling for educational level and income level, they found that these were no longer significant. But we can't just talk about getting to a dentist. This is a study I found interesting, looked at medical expenditure data at about 120,000 kids between the years of 2001 and 2016. And they found that across all groups, we were getting better at advising kids and parents about seeing a dentist and about dental care. But over that year, there was literally no difference in how frequently these kids were actually getting to a dentist. So that brings us into the interventions that we can do. And I am just going to very briefly go over this because these could be two different talks all in of themselves. But two of the kind of evidence-based interventions that we can do to either prevent or arrest dental disease are applying fluoride and dental sealants. Fluoride can be performed by any provider. They recommend putting it on children's teeth on a risk-based strategy every 3 to 6 months. As soon as the first tooth comes out, the kind of best way to do it is to dry the teeth off with gauze. And afterwards, the children can eat and drink soft foods, but you want to advise the parents that they shouldn't brush their teeth that night. Sealants are something that are put on by dental providers. They're applied to the molars after they erupt. They last 2 to 4 years, and they're recommended for all children. And actually, some adult insurances do cover sealants. I should say commercial adult and dental insurances cover sealants, and ours actually does. There are also, because not everyone has access to these programs, there are also public services that are used to address preventing dental disease. And fluoridated water is a very successful public intervention. It was started in 1945 in Grand Rapids, Michigan. And by 2016, 73% of the US population has access to fluoridated water. It's been shown that communities that have access to fluoridated water saw a decrease in tooth decay by about 25%. And Maine ranks 23rd in the US, which means our population, about 79% of our population is served by fluoridated water. Does anyone want to hazard a guess as to which community has the best rate of access to fluoridated water? Anyone? Residents in the room? No, in the US, which state? Yeah, has the best access? New York? Anyone else? So actually the state with the best access is Kentucky. About 99% of their population has access to fluoridated water. The worst state in the US for fluoridated water access is New Jersey. They only have about 15% access. And this has to do with different governments' decisions to add fluoride to their water. Another program that aims to prevent dental disease are school sealant programs. They're funded at both state and federal levels, and the idea is that they access children where they're at in the schools to provide dental sealants. And what they found is that these dental programs are actually effective at accessing these high-risk kids. They found after implementation of school sealant programs, the rates of dental sealants nearly doubled in kids who had identified as Mexican American and those from low-income households. But sometimes you need services beyond the basics, and this is where our local resources come into play. And this is one of the major roadblocks that I feel like I've experienced in the last 4 years as a pediatric provider. So I'm going to review a few different ones. This is the Partnership for Children's Oral Health. They are an organization that works to promote strategies in multiple different arenas to help promote oral health care. And this is a great tool that they have on their website, which I've included below. where you can basically look at a map and zoom in and click on all of the available dentists. And this tells you what kind of dental office it is, what services they provide, when they're open, what's their phone number, and you can copy and paste it right into the kids' AVS. One of the programs that the Partnership for Children's Oral Health helps organize is From the First Tooth. And this is a program that works in primary care doctors' offices in order to raise awareness around preventative dental health care. They work across New England, including here in Maine, and they have trainings and challenges in order to raise awareness around some of the preventative guidelines that I've already talked about. Because we talked earlier about the immigrant community, I wanted to mention the Maine Access Immigrant Network. It was founded in 2002 by the Somali community, and they have community health workers that help immigrants find both health and social services in the greater Portland area. They also host workshops and events to try and increase people's access. They have expanded services beyond the Somali community to include people from South Sudan, Rwanda, Burundi, and the DRC, and they're currently working on expanding to Middle Eastern immigrants as well. And I included their website on this slide. The last resource I wanted to talk about is mainly teeth. This is a mobile dental clinic that we can refer to through Maine Health. They have pediatric specialty and experience with kids with special needs, and they provide both preventative and emergency services and can help organize outside referrals. They have a number and a website there. So that brings me into a few future directions for the state of Maine. There is a piece of legislation out there looking to establish an oral health care coordinator and also to expand school-based programs, so everyone's aware of that. And then there's also this idea of the virtual dental home. This is actually currently being trialed in Head Start programs, where you have an embedded dental professional in the pediatric office, which can evaluate children while they're there and then conduct e-consults for dentists in order to get expedited referrals for urgent issues. This is an integrated dental model that could be the future of pediatric care. In the meantime, maybe using mainly teeth as your virtual dental home, if you don't have someone embedded, is a possibility. So that's a lot, and as promised, I was not going to go over time. So I just wanted to review some of my learning points, which are that there certainly are disparities that exist between different groups, including racial and ethnic minorities, although we do see heterogeneity within the immigrant population. Certainly see disparities in children from low-income families, and we see disparities in children with special healthcare needs, in particular kids with autism, developmental delay, and congenital heart disease. We can provide anticipatory guidance, and this certainly does seem to have evidence behind it, including discussing decreasing sweets and decreasing bottle use as a comfort measure, as well as maybe like not sharing utensils. And in general, I would say, yes, you do still need to tell your patients that they should brush twice a day. There are local resources that we can refer kids to, but the main piece that I really want to leave you guys with is the importance of timeliness, because once these kids age out of their Maine care at 21, and once they move into adult public insurance, their access to preventative dental care completely evaporates. And that brings me to our case follow-up. We applied fluoride to the 5-year-old's teeth and then got them connected with community dental, and she was able to follow up with the dentists there. However, our 26-year-old continued to struggle with getting access to dentures, and I'm not sure that she was actually ever able to. At least the last time I talked to her, she still didn't have teeth. These are my extensive references, and I also wanted to put a few thanks out there, including Dr. Poulin and Dr. Powell, who helped look over my slides. And I wanted to thank the Maine Med librarians who helped me find all of these articles. I sent them a lot of requests. I wanted to, I'm going to probably butcher her name, but I want to thank Becca Matsovich from the Partnership for Children's Oral Health, who provided me with a lot of information. And then I wanted to thank my co-residents who have been supportive of me, Med-Peds, IM residents, and specific shout outs to Jesse and Ariel, who have been with me for the last 4 years. I will remember Bryant Pond fondly. Any questions? I saw that one had kind of popped up from Dr. Hubbard earlier. She had mentioned, did you find anything about increased risk of caries with drinking seltzer or acidic beverages, even beyond soda? I did not specifically look at that, but that is a good question, especially because I feel like I drink an excessive amount of seltzer. If anyone else knows, I will look that up otherwise. Yeah, sure.
Did you think that the travel using hats for minutes, that it's still recommended to get the fluoride treatment?
So the question was, if the toothpaste contains fluoride, should you still get fluoride varnish? And I think in general, the answer is yes. If you're using a fluoride toothpaste, you still should be getting fluoride varnish. Any other questions?
I didn't see any other questions, Erica, but please, people, feel free to ask Erica questions. It was an excellent talk. Initially, I think both Dr. McCarthy and I were concerned that you might have bit off more than you could chew, but you did an excellent job of incorporating lots of information in a very meaningful way, and the cases were excellent.
Thank you. Yeah, I definitely had a little bit of that feeling myself. So, but I set out to answer a question, and I think I finally do. I feel a little bit more comfortable about giving advice about dental care. All right.
Well, if we don't have any other questions, everyone will get 10 minutes back in their day today, thanks to Dr. HIDU.
All right.
Thanks again, everyone. Don't forget the Moose and the Frank for the radiothon. Thanks.
Great job, Erica. Are you still there? You're muted. Oh, I think she's gone. I was going to tell her